Next speaker is Dr. SUJEET MISHRA. He will be talking on the limitation of artificial intelligence.
Thank you, Dr. J.J. Agrawal, sir, for giving me this opportunity. So, I'll be talking about limitations of artificial intelligence. So, what is artificial intelligence? It's a branch of computer science in which machines mimic the cognitive function of human mind. What he says, AI scares the hell out of me. And it's capable of vastly more than almost anyone knows, and the rate of improvement is exponential. And with this potential tool, the role I have been given is to tell the limitation of the brightest child of the class. So, limitation always doesn't mean pointing the negatives. It's about critically analyzing so that effective improvisation can be there in the system for its better future. So, if we look at this whole scenario of artificial intelligence, what we are doing, we need to have resources. Those resources undergo assimilation, and then it comes to its application, and then its impact or relevance. This is the whole scenario of artificial intelligence. And for resources, what we are looking for, we are looking for the data, which is dependent upon methodology of capturing, resolution of imaging, because we are talking about ophthalmology, so imaging is important. That resolution, it will vary with time depending upon the resources available for data capturing. When we went to nanoparticles, many things changed at the level we are working. So subset of information will keep changing, keep improvising with change in resolution, so will be the outcome. It's an ongoing process of improvisation till we enter the phase of consolidation. Do you think that is possible? That's an ongoing process. If you say it is consolidated, then everything is over. Information collected at microscopic level will be entirely different from what you capture at macroscopic level. And then area of interest, where you are going to use that information. So that area of interest, okay, ophthalmology, more imaging based, but will it be applicable to all the branches? That creates a big limitation in data collection. Then assimilation is analyzing available resources into meaningful tool. This needs use ambience creation to exactly simulate the recipient bed. And this needs gross to subtle details of optimization. Now regarding subset of data and its interpretation, by just few pictures I will show you this canine and human interaction. All these pictures will show that interaction. Here also there is an interaction between human and canine. Here also there is an interaction, and here also there is an interaction. But there are a lot more beyond these pictures, which I will call data here. So it is just a collection of data and its interpretation. There is an entire world lying in between. When it comes to application, the ground zero milieu will decide whether the suggestion is practical or not. Even if the suggestion is correct, its applicability will vary from place to place, that is recipient bed. And need-based customization is the real issue. And then its relevance, what impact the customization is going to create, whether it is useful or significantly useful or not. Many a times, even if it is right, the compliance issue will come from that point of view. What is its practical significance? So many things in Indian perspective will have entirely different relevance if you compare to Western world. So we are still in the very early stage of what AI is really capable of. Many data, many informations are there. Just as a prototype with this article, I am trying to highlight various methods for use of artificial intelligence in diabetic retinopathy cases are there. And if you look at the specificity and sensitivity, then what does 90% sensitivity and 90% specificity means? 1 out of 10 cases is missed, and 1 out of 10 cases is falsely diagnosed positive. So the pool you are creating with this present tool, you will have this limitation: someone will be missing out and someone will be aggressively chasing. So lost one genuine patient and unnecessary addition of one unwanted patient to the disease pool. This is the meaning of this. For cost efficiency and cost effectiveness of the system, it has to be robust and foolproof. We have many tools in the form of ID, XDR, Red Marker, IART, Google. Many are there. But all the algorithms that you see, let me tell you the example of OCT. So what the consensus is, the reports of two different machines are not comparable at current level. That is the position. So retrospective versus prospective studies versus randomized control trials. There are few randomized control trials of AI system for DR to date, and metrics do not reflect the clinical applicability in these cases. And it is difficult comparing different algorithms, as I told you. Challenges in generalization to new population and settings, and logistic difficulties in implementing the AI systems. There are human barriers to AI adoption in healthcare and access and affordability. So these are the limitations that we are coming across as per the one reference I showed to you. This is another example, well known, CSME, now we call it DME. What is the message? Your definition itself is evolving. This is just one prototype. So in this ongoing process of improvisation, revision, perfection, your database is unstable. So when this database is unstable, then all the flowchart I showed is vulnerable. So with evolving understanding and modification of disease process, evaluation and management, the database has to be upgraded. Entire AI created on older understanding is at stake. So what I am saying is, artificial intelligence is a very good tool. You should use it, but make it perfect. Way back 2013, it's about, I've told many times, I heard about this femto, and I went to ESARS for hands-on training. Only one question I put to them: before jumping to the market, why you didn't fine-tune it more? Of course, this question annoyed him. But this is a question, this is a natural reaction from any person like me. When you introduce a system for its applicability, let it fully grow, let it fully mature, and then you then you utilize it across the population. So by saying that, limitation means it has to go through many phases and processes, and then later on we will have to see what is its applicability across the population. So it is essential to ensure that algorithms, data sets, and decisions are auditable, and when applied to medical care are clinically validated and explainable. Policy framework should require design of AI systems in healthcare that are informed by real-world workflow and human-centric designs. And lastly, it should be ensured that healthcare AI solutions align with all relevant ethical obligations from design to develop to use and to be delivered properly in the real world. Thank you very much.